Hello, this is Chapter 16, Part 2. We are continuing our discussion about giving birth. And this is a typical um, labor delivery recovery room. Most hospitals do this. They don't do it at Freeman, and I don't know why. But as you can see there, in the middle of the room is the bed, the birthing bed. And you see the stirrups down on the bottom, and actually that bed comes apart and it becomes a birthing bed. And you put the lady's legs up in the stirrups, and away we go. And on the left there, you see the monitor for the computer for the fetal heart monitoring and other data entry, and then the fetal heart monitor itself. Excuse me. And on the right, here in the foreground, is the radiant warmer that they will place the baby on after birth. It has suction, it has oxygen, it has a warming device. It's had a temp probe so the baby doesn't get too warm. It has an O2, I believe it has an O2 sat monitor on it as well, and it has some resuscitation supplies probably in the drawer. So this is very, very typical. So we're gonna be talking about this a little bit more in class, but we'll talk quite a bit here about the stages of labor. This is one of your slows. There are 4 stages of labor, and under stage 1, there's actually some sub stages, if you will. So we'll talk about those. So here we go. The first stage, we have the latent, the active, and the transition. We have the second stage, we have the third stage, and we have the fourth stage. Yeah, so there you go. And we're going to get into this here as we go. So normal labor, again, we touched on this in the first part, a little bit about why we think labor starts. There's a lot of factors, but remember, we're talking about someone who is full term, not preterm, not 28 weeks or 32 weeks, or someone that's 38 to 40 weeks, term pregnancy. So they're thinking that maybe there's changes in the maternal estrogen, there's prostaglandin secretion, there's increased secretion of oxytocin, which stimulates uterine contractions. And even the baby gets to stretching and moving, and even they're thinking that this may irritate the uterus, and the uterus is like, okay, I'm pushing this thing out of me. I don't want it in here anymore. Okay. So sometimes we have some premonitory or warning signs of labor may be starting. Okay, these are not hard cast in stone rules, but they're pretty common. Braxton Hicks contractions. Now those are not true labor contractions. Braxton Hicks are practice, if you will, for true labor contractions, and so they may be bothersome. They're typically just in the lower abdomen. True labor contractions usually start in the lower back, and they just kind of come around to the front, and they increase in intensity, and they get closer and closer together. And the number one thing about true contractions is it changes the cervix. It faces the cervix and dilates it. Braxton Hicks do not typically do that. And usually it can go away. Sometimes really walking or drinking extra fluids can take care of it. But usually in Braxton Hicks, the presenting part is way up high. It's like a -5, way up above those ischial spines we talked about earlier. Lightning, remember that term. Remember, the baby is moving down with the presenting part toward the pelvis. It's getting down there. And so you may have heard someone say, boy, her baby's really dropped, and she was way up here, now she's down a little bit. And she may say, yes, I can breathe deep now, but boy, I'm having to go to the bathroom a lot because of the pressure on the bladder. There may be more vaginal secretions. They're not necessarily bad. They just kind of happen because of all the stuff going on. The bloody show, that may happen possibly as a result of the mucus plug being expelled. The mucus plug may be expelled and labor may not occur right away. It could. You just don't know. But there may be more bloody show because the cervix may be changing. Okay, we don't know yet. Sometimes women will get an energy spurt. We've got what we call nesting. They'll clean the house. They'll get all the meals prepared ahead of time. They'll get their suitcase packed and ready to go by the door, and they're nesting. They're getting ready for the baby. And maybe a small weight loss, although that's pretty unusual. Okay. So true or false labor. Sometimes people come in and they think they're in labor, but it's called false labor. True labor does change the cervix. okay? If they're ever certain about if they're in labor or not, they probably should come in and we'll check them out and see what's going on. So let's talk a little bit more about true and false labor. True contractions, like we said, begin in the lower back and extend from the back around to the abdomen, okay? And it usually, if it's contraction, you can palpate it on the uterine fundus. It feels very firm. You cannot push in it very much. You cannot indent your fingers. The contractions themselves, they get more intense and firmer and harder. They get more frequent and they last longer. And the number one thing is the cervix gets thinner and it gets wider. It dilates. Okay. So this is from your book, and you can certainly read this in your book, but you can see here that false labor versus true, and it's pretty much consistent with what we've been saying. And walking tends to increase your true labor contractions versus the other. The lower back, and again, we talked about that. False labor, they just kind of bug you and bother you, and they're like, oh, I don't like this, I'm uncomfortable. Whereas real labor, as it progresses, it's going to be very noticeable. And then the cervix, of course. Okay, so contractions have a cycle, if you will. We have the increment or the crescendo where it goes up and it's getting stronger and stronger and stronger, and it really gets firm for a while. We call that the peak, or some books call it the acme, A-C-M-E. And then depending on how strong it is, it may have a higher peak on our fetal heart tracing paper. And then as it starts to go down, the decrement or the decrescendo, it starts to go down, and the uterus, we hope, will have relaxation in between contractions. It's very important for it. We try to palpate it to make sure it's soft. We encourage mother to relax as much as she can when there's no contraction, because that helps her conserve her energy, and it also promotes placental flow as well. We're getting more into this in another lecture. But when we're talking about contractions, we want to time them. Okay, how frequent are they? How often do they happen? So we time that from the beginning of one contraction to the beginning of the next. Okay, that's the frequency. Timing of one contraction when one starts until the next one starts. So it could be 5 minutes, could be 3, could be any number. Then the duration, how long do they last? And so if a woman is timing her contractions, she may say, okay, now, and then her partner or herself, they may time it. It may be 30 seconds, it may be 40, just depends. But we also, remember, we want to make sure that it's relaxing in between. And then again, the frequency, the duration, and how intense, how strong is it? Usually they start off sort of mild. You can feel them, but they're not terrible, and the mother can usually manage the issue. But as it gets progressively stronger, then it's a different story. Okay, here's some more. Here's the frequency, it's time from the beginning of one to the beginning of the next, duration, and then here's just some pictures of how it happens. You see, number one, the cervix is not effaced or dilated. It's thick and it's long. Okay, as it starts to dilate or efface, it thins. It typically thins before it dilates, because a thick cervix will not dilate very well. A thin cervix will dilate more easily. And so you see that it's fully effaced. It's as thin as almost as the edge of a piece of paper, almost that thin, to 1 centimeter. And then as the baby's head is moving down and pressing, and the uterus is contracting down, the baby is being forced, and now the cervix is dilated 5, and then there should be no cervix left if it's fully dilated to 10 centimeters. You won't be able to feel it when you do an exam. Okay, so vaginal exams are done by registered nurses who work in labor and delivery. And as a student, I doubt that you will get to perform one. You might get lucky. I don't know. It's a sterile procedure. You must have on sterile gloves to do this. Okay. Before we do the exam, we thoroughly clean the perineum of the woman. Okay. She may be sweaty. She may have a lot of blood show. We just want to clean her up really good. We do it from front to back. Okay. and we clean her good, and then we don't do these all the time. We only do them when they're warranted. Okay. For instance, we do one before we give analgesia or anesthesia like an epidural because we want to see what happens. Sometimes we do the epidural and she's maybe at a 3 centimeters, and we do the epidural and she gets relaxed, and all of a sudden she's 5 to 6. We want to know that. Okay. Um, we want to determine the progress of labor. Okay, she's been in labor 2 hours, and she's getting very, very uncomfortable, and so on and so on, and we may do a check. Okay, and then we want to make sure that at the second stage, from complete dilation to the birth of the baby, that she can start pushing. We do not want her to push unless she is completely dilated and completely effaced. Remember, we measure dilation in centimeters. We measure effacement in percentages. Okay, we do not want her to push until we know that. So here's just a picture of some. As you can see, the one on the left, no dilation. Then the one in the middle there is a 9 centimeters, and then cervical dilation by vaginal. One finger is usually 2 centimeters. Two fingers is 3.5 to 4. It depends on the size of their fingers and so forth. So it's not an exact science, but it's pretty close. So the mechanisms of labor are very, very important because this has to happen in order for the baby to move through the birth canal. Okay, so these are very important to kind of remember. I wouldn't doubt that you don't see this on state boards. I'm not sure if I'll put it on a test, but it's a good idea to know it. So descent obviously means going down. Head's going down, whatever's with it goes with it, right? The engagement of the presenting part. Remember we talked earlier about the 0 station, at least 0 station, sometimes +1. The fetal head is flexed, and then the baby has to turn a little bit and get the head down in that under that pelvic rim, and then it will turn, and then it will extend its head, and then it will rotate again, and then the head comes out, and then the shoulders. It's very interesting. So here's a diagram. As you see, A is descent. Okay, the head is down very much. Okay, B is flexion. The head is tucked down on the chin. The chin is tucked down on the chest. I'll say it in a minute. Chin on the chest. Okay, and then as you see C, it starts to turn a little. Okay, so that it can get under that pelvic bone there, right there, at the back of the head there. You see that pelvic bone. It goes down, and then it turns, and then we can get the shoulders out, and the baby's coming. Okay, so descent, flexion, internal rotation, extension, and external rotation. Okay. So how long labor lasts varies from woman to woman, but women who have never given birth typically take a little longer to get a baby out. Now that's not, again, it's not a hard and fast rule. Some women just have a baby and it's like nothing happened. Others have a more difficult time. So it just depends on your woman, but typically a primipara, or someone who's never had a baby, primigravida, she is going to take a little longer. Women who've given birth previously, especially if the pregnancies were close together, everything's been stretched, the pelvic floor may not have very much tone, everything comes out a little easier. Okay, everybody's different. If a patient says to you, my first baby came very fast, you better pay attention. That's called a precipitous delivery, which means that labor lasted less than 3 hours. You go, oh, that'd be great. I'd love to have a labor less than 3 hours. No, you wouldn't, because the baby is put under tremendous stress and they have to hurry and get everything in and out of there. And sometimes they get stuck. So it's not necessarily a good thing. So if your lady says to you, my last two, I barely made it into the hospital. I almost had them in the car. Then she needs to come to the hospital at the first sign of anything, in my opinion. Okay. So here's, again, this is from your book. I don't remember the page. You can find it. When to come to the hospital or the birthing center, whatever she decides to do. These are things that, if she's having contractions, if her membranes have ruptured, if she had a sudden gush or a trickle, or just to make sure that either she has or has not. And we can do a test to see if it actually is. Bleeding, if there's bright red bleeding, that should, if it's bright red, usually the bloody show we talk about has a little bit of mixture of dark red in it as well. Normal blood show is thicker, more pink or dark red, and again, there'll be mucus with it as well. Decreased fetal movement, of course, is always concerning. And if they just don't feel right, something doesn't feel right, they need to come in right away. So anything that could compromise the fetus is something that we need to be aware of. And so that's why if we think we're in labor, we want to get women in here and get them checked and make sure everything is good, or if we need to intervene. So a fetal heart rate pattern outside the normal range of 110 to 160 would be a cause for concern. Meconium stain. So meconium is the initial stool or feces, if you will, of a fetus / newborn, because they have not ingested anything other than anything from the amniotic fluid, the placenta, and so it's just dark. There's no enzymes in it. There's nothing like you and I would, our food, and so it's this greenish black, and it's very thick and sticky. And so sometimes if babies are in distress in the uterus, either from placental insufficiency or loss of oxygen, something, their anus relaxes and they pass meconium. And so it may come out in the amniotic fluid. It would be greenish. I've seen it anywhere from just a light tinge. I've seen it come out looking like green pea soup. And when that happens, that's bad. You need to take that baby C-section if the green soup comes out. A slight meconium tinge might not be anything bad. We're going to watch everything very closely. Anything that's cloudy, nasty, smelly from the amniotic fluid could represent an infection. Again, excessive frequency or duration of contractions. In other words, they're coming every 1 to 2 minutes and there's very little relaxation time. That could put that baby at compromise. Maternal hypotension, again, is a big issue. Get her off her back. Maternal hypertension is another thing, especially if we're worried about preeclampsia and so forth. We'll be talking about that. Maternal fever, as you see here, 100.4. Well, that's not very high, but for a pregnant woman, it's high. Could be higher, okay? And then in chapter 17, which we'll be covering later, you'll hear more about that. Okay, so when a woman is in labor, she needs some special care. So let's go back and stop right here, and let's go back and kind of review the stages of labor, okay? So the first stage is, we call that, and we have three phases. It's called the early, active, and transition. Okay, early, active, and transition. All right. Then the second stage is fully dilated cervix and thin and effaced to the birth of the baby. So let's just say the first stage is from the contractions first start to full dilation. And then the second stage is full dilation to birth of the baby. The third stage is delivery of the placenta and all the other products of conception. And then the fourth stage is the immediate postpartum period, usually 1 to 2 hours. It can be extended. Okay. So first stage, we're going to stop right here. We're going to do first stage, onset of contractions to full dilation. Okay. We have the latent or early phase. That's usually when the cervix is 0 to 3 centimeters. Okay. We have the active stage. The cervix is dilated 4 to 7. And then the transition is from 8 to 10 centimeters. And you can see how that could be called transition because we're moving along, going toward birth. Okay. So the first stage, the cervix is moving more anterior toward the front of the mother's pelvis. It's softening. It's getting thinner. Okay, we call it ripening. These are all signs of progress, even though there may not be great contractions yet. This could be happening and the mother not even know it. Okay, she may have some cramping or pressure down there. Some women call it like a really bad menstrual cramp. Could happen. She may be excited. She could be really anxious. She's not quite sure what to think. She might be a little bit apprehensive at this point. She's like, oh, this is it. This is really it. It's going to happen. Okay. All right. The active phase or second phase or active labor. It's the first stage, but it's the second phase. This is kind of confusing. Active labor. Okay. The cervix is dilating 4 to 7 centimeters. Contractions are increasing in intensity, in duration, and frequency. So they're getting harder, they're coming faster, and they're lasting longer. Okay. At this point in time, more than likely, a woman's going to ask for something for pain, and we're going to try, especially if we can, even if we use other methods, we want to offer non-pharmacologic things like helping them with breathing, counter pressure on the sacrum, especially if they have a lot of back labor, hot and cold, making sure they're clean. If they're able to get up or get them to the bathroom, let them urinate, and being very supportive of her birth plan. Most of the women have a birth plan. A lot of them say, I don't want any drugs, or I want to go all natural. And then they get to be about 4 centimeters, they're like, give me the epidural. So it's okay. We can change that. But we try to follow their wishes. They may not want anybody in there, but their partner, spouse, whatever. They may want the whole darn family in there. We don't know. So it just depends on what she wants. Now, of course, we're going to use good judgment. We're not going to have any safety violations. We're going to make sure we follow infection control practices. So we do have some control over it. But by and large, we try to follow what she wants. Okay. So that's the first stage. Second phase, or active labor. 4 to 7 centimeters. Things are really clicking. They're moving right along. Okay. And she may be anywhere from excited to tearful to scared to, it could be any number of emotions depending on how well we manage her pain. Now, if she has an epidural, most physicians will not put in an epidural until you're about 4 to 5 centimeters dilated, because initially an epidural can slow labor slightly. So it just depends on your physician and your facility policy. But if she's got an epidural on board, she's cool. She's not having any problems. But if she's trying to take it, natural, and she's just getting little increments of pain medicine, it could be, that's when you typically think about the woman screaming at her husband that you did this to me and all that stuff. So now we're in the first stage and we're in transition. The cervix is 8 to 10 centimeters. The contractions are getting harder, much harder. They're lasting longer, and they're becoming more frequent. They're about 1 minute to 2 minutes apart. Okay, and there may be other signs of progress. Okay, she may say, oh, there's a lot of pressure down there. I feel like I'm going to pee on myself, or I may move my bowels, and that's okay. We'll check, but if that happens, it happens. And sometimes they get very nauseous and they throw up. And this is when they really seem to lose their minds. Sometimes they start screaming and hollering, and I can't do this. You, the nurse, have to be there, be present, take charge. Lots of times I've had to say to a woman, look at me, look me in the eye, look at me, focus. Okay, I'm here. You're doing fine. You can do this. You have to inspire her. You have to encourage her. If she has a supportive person with her, get them involved as well. It just depends on your situation, but you have to be there, and you have to take control. Sometimes you have to be almost like a mother figure in a way, and sometimes mothers are there and they're not much help, but there's people, well, you don't have to carry on this way. It's not happening to them. So she is your focus. She is the queen, and we have to make sure she's doing well, because if she tenses up and gets all nervous, and it's going to slow her down, and she's going to be miserable. So take charge. Get her focused. Okay. She's going to have more bloody show at that point in time. Okay. So as she's progressing at this 8 to 10 centimeter mark, we're really going to be watching her vital signs and watching that fetal heart rate. We're watching to see how that baby's doing. We will reposition her as much as we can. It's good to move her from side to side if we can, because that will relieve pressure. Can also help us help that baby move through that birth canal and go through those movements of labor that we talked about. Again, take charge. Don't scream at her. Just use a firm tone and have her make sure she's focusing. Stay close by. If you have to leave, tell her, and be very matter of fact, and be truthful. I'll be back in 5 minutes, and you better be back in 4, because she's going to be hollering for you. Acknowledge that she's in transition. It's tough. Acknowledge that. Give her the credit for that. And then, of course, let her know that she's doing exactly what she should be doing if that's the case. And if she feels an urge to push, say, don't push until we check you, because we don't want you to push against your cervix if it's not dilated, or her face, because if she does, it will bruise and swell and it will slow her down. And so we don't want her to do that at this point. Okay. Now, the second stage is from full dilation to birth or expelling the baby. Okay. So we're moving from a 0 station to +1, +2, all the way down to 4. By the time they're 4, they're crowning and the baby's coming. Okay. And they'll get that urge to push, and that's called Ferguson's reflex. And oh, I got to push, I've got to push. And you listen to them when they say that. Okay, you listen. Encourage her to bear down and do it properly. Okay, so let's go back here now with our current slide, and let's talk about all the things that we can do to help her relax and cope. So the lighting of the room, we don't need bright lights on at this point, low lighting so that we can at least see what we're doing. Keep the room kind of cool, okay? If she's cold, then we cover her up, but make sure she's clean, okay? Keep her perineum clean. Keep the pads under her changed so that they're not wet. She might need mouth care. Maybe she's taking ice chips, but maybe she wants to rinse her mouth or something. Keep her bladder from being full. If she has an epidural, she might not feel the sensation that she needs to urinate, so we will do the in and out cath, the red rubber catheter, drain her bladder, pull it out, okay? Sometimes have been occasions that I have remembered that we put it in once and she's in labor a long time. They'll say, next time you have to put it in, do a catheter, just leave it in. And so we can do that. Water, they need water because they're working a lot. They're working hard. So yes, they have IV fluids, but they definitely need water, ices, things like that they can take. Encouragement, and of course, pharmacologic pain relief. The epidural would be done by the anesthesiologist, but maybe we're given little increments of something to help with that pain. Okay. So, pending birth, okay? You have to be alert especially for a woman, it's their second, third, or more baby. If she says, oh, the baby's coming, or I got to push, or she starts grunting, you better pull the covers back and look, because you could have a crowning baby and the baby may be born in the bed, which is not ideal, but it's okay. The perineum may be bulging. You may have crowning where the presenting part is coming and you see it at the vaginal opening. And sometimes when she pushes, it'll come out, and then if she stops pushing, it may retreat a little, but as time goes on, it will stay out. Okay, so obviously the baby is coming. Okay, so when we talk about pushing, there's effective pushing and then there's ineffective pushing. All right, excuse me. So this is what you see on the TV. Their eyes are clenched shut. They're screaming. They're cursing. Their back is arched, and they're acting a fool, and they're trying to move up to the head of the bed, and they're trying to get away from it. That's ineffective. It will not do anything but wear her out and make you crazy. So we want to make sure that we say, hey, this does not work. Listen to me. This is how we're going to do it. And so we're going to teach her better pushing, okay? And we're going to tell her to relax in between contractions, okay? So we're going to keep, again, all this time is going on. We've got a lot of things going on. We're watching the IV site. We're watching the heart rate of the baby. We're watching her vital signs. All kinds of things going on. So we're resting in between and then repositioning her if we need to. So what we typically do when we're wanting her to push, we have her take a deep breath in, and then her chin down on the chest, and she's pushing down. Tell her to visualize pushing that baby out downward, on the order of, really constipated, you're trying to have a bowel movement. That kind of pushing. No screaming, no shouting. Save your air. Okay, when she needs tell her when you need a breath, take a breath. And then get right back to pushing. Okay, usually with a contraction at this point in labor, they can get at least 2 good pushes, sometimes 3 out of 1 contraction. And so you're watching the monitor because again, with an epidural, she might not feel them. So we're watching the monitor and we're watching that contraction to start and say, okay, we're here comes a contraction. And so you coach her, you and whoever's with her, you coach her through that. And then again, reassure her when the contraction's over, tell her let her breath out. And just relax, let it all go. That's very, very important. And make sure you're watching your baby's heart rate while this is all going on. So sometimes there's more than one nurse in the room to help with managing all this. Okay. So your responsibility. We prepare a delivery table, a sterile table, and I'll have one of those available for us. We want to cleanse the perineum before everything starts, so we'll show you a picture of that. I think I have a picture of that. Yes, I do. Okay. Usually we use just soap and water, maybe some chlorhexidine soap. This depends. And then once the baby comes, there may be a nurse in there to take care of mother solely, and then another nurse will receive the baby in the room. It just depends on what's going on at your facility. If you think, and maybe there's reason prior to all of this, that you have a neonatologist or a pediatrician on standby, you call them then and say, hey, we had slight meconium staining, you might want to be here, that kind of stuff. And then, of course, you might want to give oxytocin if it's not already in the IV, maybe some Methergin to help that uterus clamp down, so forth. Okay, then this is how you cleanse the perineum. Okay, you can see there on the top left, it shows you kind of start from the end and go, you go down, and you go to the sides, and you go down just like you would put in a Foley. And as you can see, as the head is coming out in that middle top picture, you see that there's they've got a towel there, and they're controlling the head because you just don't want it to pop out and really tear the perineum. So you're controlling the head. That's called Ritgens, R-I-T-G-E-N-S, Ritgens maneuver. I guess Dr. Ritgen perfected it. I don't know, but it helps control the head, and it also helps that head to rotate, that external rotation we talked about earlier. Okay. In the bottom left, as you see, there's a nuchal cord. That's another reason to control the head, because that cord around there tight, you might not be able to deliver the rest of the body. You may have to cut the cord right then and there to get that baby out. Okay, so then we're going to get the cord from around the neck, and then we're going to deliver the, we're going to pull down and deliver the anterior shoulder first, and then pull up on the head and deliver the posterior shoulder. And then everything else comes out pretty good after that. Okay. Alrighty. So this is the second stage. Now, the third stage, the baby has come, and now we're going to get rid of the placenta. All right. We're going to get rid of the placenta. So that usually happens, within 10 to 20 minutes, the placenta will come. And to help kind of move that along, the physician will do a little fundal massage, and that will help the placenta to separate. Signs of placental separation. These are important to remember. This is a sign that the placenta is coming away from the uterine wall and is being expelled. Okay, the umbilical cord gets longer. Okay, the doc has already cut the cord from the baby, and there's a little bit of cord still hanging out of the vagina. It will get longer because the placenta is coming. Okay, there may be a sudden gush of blood from the vagina, and it usually is just that, one gush. Okay, and then the fundus starts to get more rounded and more globular, and then the doc will massage that and make sure that it's firm. And then once the placenta is delivered, then the doc will inspect it and make sure that it looks intact, that there doesn't seem to be any pieces missing, and check all of that. And then the fourth stage, of course, is the first 1 to 2 hours postpartum, and it may be longer depending on your situation. So we're not going to talk about that in this session, but we will be talking about it later. Okay, so another part of our responsibility is we want to and these are very, very, very important here, very important. We want to make sure that we keep that baby, that it's breathing, and that we keep it warm. Very, very important. So that's why after the baby's born, we wipe it down. We make sure there's no moisture on the skin. There may be some vernix, that cold cream stuff. We just leave that alone. But if there's a lot of mucus and fluid, we wipe that off. Okay, we're checking those respirations. Okay, we're making sure that baby's crying, that their color is pink. We're doing our 1 minute and 5 minute APGAR scores. And then, of course, the thermal regulation, because if babies get cold, they do not do well. It drops their blood sugar and they get in all kinds of trouble. So that's why we have them on we have the radiant warmer, and we might put them on that, or we might put them right up next to mama, that skin to skin contact, which is great. That will help keep the baby warm. We wrap them. We might put a little cap on their head because it loses a lot of heat through their head. And then, of course, we want to make sure that we properly identify the infant. And so the mama has a bracelet and the baby has a bracelet, and the numbers on those bracelets have to be identical. And you put one on the baby's foot, and you put one around mama's wrist. Okay, and every time that baby is taken out of the nursery to the room and from the room to the nursery, it's identified with those two markers. A little later on, they might get footprints. Depending on the baby's, how the baby's doing, they may not weigh it right away. They may wait a little bit. They may weigh it and then give it back to mama. It just depends on what's going on. For your mother's care, you're definitely watching her for postpartum hemorrhage. So you're checking that fundus. You're watching those pads. You want to promote further uterine contraction. So the fundal massage, and again, maybe some Methergen to help clamp down. And then, of course, you want to make sure that that baby and her are bonding, that daddy's a part of things. That skin-to-skin contact, and that sometimes they put the baby to breast and they breastfeed. Everybody's a little different, and so sometimes things will have a different sequence, but your number one priorities is your baby, the respiratory issue, the respiratory effort, their thermal regulation and identifying them, and keeping, of course, with respirations, that means keeping that airway clean, so you've got that bulb syringe and so forth. And then your mama making sure she's not hemorrhaging. Very, very, very important pieces of what we do. Okay. The first hour after birth is ideal for bonding, and typically we don't do anything other than what's necessary to keep a check on the baby. If the APGAR scores at 1 minute and 5 minutes are good, and the baby is warm and next to mama, we call that the golden hour. We try not to be a part of that if at all possible. We want them to be together as a family. And the good thing about this is at this time, the baby is usually very awake and alert, and mama talks to it, and it looks at the mama like, oh, here you are. And we know that they can't see very well, but they know that mama's voice. I'm telling you, they do. Make sure that we give them the privacy we need. Again, a lot of the assessments we need to do can be right there, done right next to mama. And then put the infant to breast if they're breastfeeding. And then different cultures may have different things. They may want a certain bracelet put on, or a certain blanket, or whatever. When we try to accommodate that as much as we can. So it's all about that golden hour. Very important. Again, remember, a lot of things that we can do as far as assessment goes, we can do as the baby's being held by mama. And there are my references